In the Veterans Administration health system, there's a box for diagnoses that are pre-existing, and if someone has been diagnosed with that, and that diagnosis has been linked to their primary medical problems, then it's usually there. So you can see it. However, some patients may have been diagnosed with something else, such as anxiety or certain personality disorder, that later on, after several visits, could end up being diagnosed with PTSD. In our study, we looked at the Veterans Administration, particularly because that's where our study took place. That doesn't mean that there are no PTSD patients who are admitted at non-VA hospitals. There are veterans who have PTSD who are admitted to non-VA medical centers, and there are non-veterans who have PTSD from other causes, such as rape, for example, or car accidents, or even a horrible event that preceded their admission, who end up at other hospitals. We thought that proper awareness to the PTSD component of medical care in general, and ICU care in particular, especially that we looked at people who are on a breathing machine, on a mechanical ventilator for more than 24 hours. So we think that this awareness should not be limited to a Veterans Administration medical center, but also every physician, not simply a critical care physician, but every physician, in the emergency department, or in the intensive care unit, or in the regular ward, or even if it's a surgical ward, to keep an eye on that, especially when it comes to using sedatives, because agitation could be treated with sedatives, such as benzodiazepines, or it could be mistaken for pain and given, for example, morphine or fentanyl. However, maybe looking at another part of their care, which we hope that we would look into in a prospective trial in the future, and see what we can devise. We're hoping in a multidisciplinary approach, involving maybe a psychiatrist as well, to see how we can devise future plans for proper care, while keeping in mind this unique disorder, and being quite well aware of what effects it can have on medical care in general, as well as the intensive care unit course in particular. So there's one thing that we did not achieve statistical significance in it, which is the mortality, but our p-value was very close. It was 0.00. It was 0.08. So we think that if we have a larger number in the study, this could probably be statistically significant, and therefore it's not simply a matter of how much sedatives we are using, but it could also affect that outcome of life and death, which is mortality. So we're hoping that maybe in a future study we could help define whether that risk truly exists, and ways of trying to avoid it. What we found out is that there's a definite significance into whether someone has PTSD, particularly in this setting, because in our study we compared two groups of veterans who had PTSD and those who did not, and we matched them for their severity of illness and age, as well as sex, even though there were only two females in each group. However, what we think is that this awareness of PTSD cannot be overemphasized. In a war zone, or someone returning soon after a deployment, this could be even more prevalent and more important in that particular setting. However, we know that this is a chronic disorder where veterans live out their experience over and over and over again. So whether it's in this setting or in the other, this awareness is extremely important. It could be much more tangible whether it's in a war zone rather than whether someone is in a hospital. However, both experiences, especially when associated with a medical disorder leading to them being on a breathing machine, and hearing all those beeping sounds and lights day and night, and every single sound in the intensive care unit, I wonder how that can affect their experience, as well as eventually their outcome. So I think proper awareness, I keep saying that, but I think it's physicians have to be aware of that, not simply physicians, but everyone who's in the healthcare. So nurses in the intensive care unit, physician assistants, nurse practitioners have to be aware of that and try to titrate their approach while taking that into account. In general, the PTSD seems to be at about 10 to 20% prevalence among veterans, and in our hospital, almost 11% of everyone who was admitted to the intensive care unit had PTSD. So that fits the 10 to 20% bracket. So it's not a trivial number. It's 10%. We looked at about 1,560 something patients, and more than 10% of those had PTSD. We included the ones that fit our inclusion and exclusion criteria, so that was about 50%. The 87 patients that we looked at were about 50% of the ones who were admitted to the intensive care unit. However, we see that this is quite prevalent. It's not a trivial number, and it's something that is found quite often in the Veterans Administration Medical Center, and as I said, in other medical centers whether there are veterans who are being admitted or non-veterans with PTSD for other causes than war. We hope to be able to move on to a prospective trial where we would incorporate a multidisciplinary team and try to devise a plan with interventions, and we see whether those interventions will lead to a difference between those who have PTSD and those who do not, and then with proper numbers we can randomize veterans with PTSD into a treatment arm and a non-treatment arm. I'm talking about the intervention that we have in mind, and see whether the outcomes would differ and whether we would have a more favorable outcome in the treatment arm, and then we can hopefully try to verify that the intervention works and disseminate it into the treatment of veterans.